Okay, good evening, everyone. This will be the second part of syndromic ichthyosis. In the first part, we dealt with ichthyosis occurring from disorders of lamellar bodies or disorders of cholesterol synthesis. Okay, so as we have already discussed that I have divided syndromic ichthyosis into three different videos so that it becomes a bit easier to understand, and I have grouped them together. I have used the same grouping mechanism as what is there in Rooks. Okay, so this second part of the lecture will focus on ichthyosis, syndromic ichthyosis, in which the problem is in the cornification process. Okay, cornification means the problem in the keratinization. So I would request you all to go back and look at the video on basics of keratinization so that you can understand where all these proteins come and why the problems or mutations in these proteins or genes encoding these proteins is leading to ichthyosis. Clear? But as I've already said that in syndromic ichthyosis, all you have to do is just remember the facts. So if you remember what is wrong in each ichthyosis, you will remember how it is going to present clinically. So the second part of syndromic ichthyosis is exfoliative disorders of cornification. So let's start with the presentation. Now, in these disorders, the proteins which are required for proper cornified envelope formation are defective. Okay, so these are defective. Or you could say that the problem or in there are problems in the process of keratinization. So there are defects in keratinization. Mostly the disorders have a problem in corneodesmosin. Now, what is corneodesmosin? We know that at the basal level of skin, it is known the cell is known as a keratinocyte. Okay, as the cell moves forward and reaches stratum corneum, it becomes flattened and dead. Okay, and corneodesmosomes or corneodesmosomes are nothing but attachment between the dead cells. So they are responsible for attaching these dead corneocytes together. The major protein required for the construction of corneodesmosomes is nothing but corneodesmosin. Clear? So if there's problem in corneodesmosin, it will have defective function and adhesion, and the skin will not be able to attach itself together, or the cells will not be attached together, and leading to exfoliation, desquamation. Okay, and that is why you see those scaly disorders like ichthyosis. So syndromic ichthyosis as a group and subgroup is disorders of cornification or the process of cornified envelope formation. The phenotype is extremely variable. Background erythema may not be present. For example, in peeling skin syndrome type A, which is a non-inflammatory type, you don't see much erythema. While in Netherton syndrome, erythroderma is a characteristic feature. Okay, so it may or may not be there. So let's start our discussion on exfoliative disorders of cornification. Remember, the problem mostly lies in corneodesmosin. Corneodesmosin. So let's move forward and discuss them. We'll quickly go through all the disorders mentioned in Rooks and other textbooks. Starting first with Comel-Netherton Syndrome, or just Netherton Syndrome as we know it. It's a rare autosomal recessive disorder, and the description is ichthyosiform erythroderma with hypotrichosis with hyper IgE. Okay, it is roughly constitutes about 18% of cases of infantile erythroderma. But in infancy, there are so many causes of erythroderma that sometimes, or in fact, most of the times, the diagnosis of Netherton syndrome is delayed. So it becomes much more important for us as dermatologists to know about the little details of Netherton syndrome so that we can easily diagnose it and start the treatment. It consists of a triad, and this triad is important. It's a good Viva question. It's a good quiz question. Congenital ichthyosis, hair shaft anomalies, and severe atopic diathesis. So remember all of these things. Hair shaft anomalies leads to hypotrichosis. Severe atopic diathesis is associated with hyper IgE, and congenital ichthyosis leads to ichthyosiform erythroderma. Clear? So just remember this triad of hair shaft anomalies, congenital ichthyositis, and severe atopic diathesis. This is important. At birth, it presents as Congenital ichthyosiform erythroderma, CIE, that we have discussed in the previous videos on ichthyosis. Go back and see that, and you will have a better understanding about CIE. So it begins as CIE. Roughly 90% of cases of Netherton syndrome begins as CIE, but it has a milder phenotype with polycyclic migrating plaques. And these migrating polycyclic plaques are known as Ichthyosis linearis circumflexa. So ILC or Ichthyosis linearis circumflexa is nothing but erythematous plaques, scaly plaques which are migrating or changing position. Okay. The major complication associated with Netherton syndrome is life-threatening neonatal hypernatremic dehydration, that means increased sodium dehydration, failure to thrive, and recurrent infections. So these are the complications which we must take care of while treating a case of Netherton syndrome. Let's move forward. So the problem lies in the mutation in SPINK5 gene. SPINK5 is serine protease inhibitor Cahal type 5 mutation, and this mutation leads to problems in the kallikrein network of the epidermis, namely kallikrein 5 and kallikrein 7. Now these proteins are required for the formation of corneodesmosin or the processing of corneodesmosin. So as we have said before that the problem will lie in corneodesmosin. Okay. Leading to, because of that, the corneodesmosin is not properly formed, then the corneodesmosomes are not properly formed, and the cells are not attached to each other. This leads to over desquamation of corneocytes and degradation of desmosomal proteins. So the corneocytes, which are normally attached to each other, okay, attached to each other by corneodesmosomes, the corneodesmosome is not there, and because of that, the cells, they shed off. The skin flora consisting of Staph aureus, Staph epidermidis, the skin homeostasis is also disturbed. And because of this disturbed in the homeostasis, there are recurrent infections. Okay. A few subset have also found that there are mutations in the caspase 14 dysfunction, and caspase 14 is required for proper processing of filaggrin. And this dysfunction in caspase 14 leads to dysfunction in filaggrin protein. And if we know that filaggrin is dysfunctional, it will lead to atopic diathesis or atopic dermatitis. Clear? So now we know why AD is an association of Netherton syndrome. Let's move forward. Now, coming to the clinical features of Comel-Netherton syndrome, in skin you see erythroderma. Remember, roughly 18% of the cases of infantile erythroderma is Netherton syndrome. Ichthyosis linearis circumflexa is seen, which are red, exfoliating or scaly, annular or polycyclic patch with an incomplete advancing double edge of a peeling scale. Now, what it is, you you will see an erythematous plaque, erythematous scaly plaque of that matter, and you will see two layers of scales at the advancing edge, at one edge. So if you look vertically, it will look like this. If you look uh, somewhat parallel to the skin or acute angle to the skin, you will just see two scales or two layered scales at the advancing edge. That is what we mean by advancing double edge of peeling scale. It is episodic and goes from cephalocaudal direction, and that is from initial stage. Remember, the child may present with generalized fully body involvement of erythroderma, so you might not be able to appreciate ILC that much. In hair, you see a characteristic abnormality known as trichorexis invaginata, in which what happens is you have a hair shaft, and the other portion of the hair shaft is invaginated inside, or it has gone inside, it has telescoped inside. So this is also known as telescoping, like a telescope, okay? Telescope, like a telescope, it goes inside itself. So that is what is known as trichorexis invaginata. Other is known as pillae torsi. So what is pillae torsi? You have a hair shaft, and the hair shaft is rotated on its long axis. You twist it. So that is pillae torsi. Okay. So pillae torsi, trichorexis invaginata, these are very typical and very important points to remember about Netherton syndrome. Rare, thin and spiky and fragile hair, and there is also slow growth of hair. The third part of the triad is atopy. There's recurrent urticaria, facial angioedema, and food allergens like nuts and fish are also implicated. There is pruritus. There's significant severe pruritus. Growth retardation may occur. Remember the complications of Netherton syndrome: hypernatremic dehydration, failure to thrive, It may lead to mortality even. Okay. So frequent dermopathic enteropathy occurs. There is failure to thrive. It may require NG tube feeding also. Infants do begin to gain weight in their second year. Okay. So if proper treatment is initiated early, the growth is somewhat, saved. There is growth hormone deficiency associated with Netherton syndrome. Clear? So let's move forward. Now look at these pictures which I've taken from Rooks and Bolognia. And first, we'll see the erythroderma. So we know that the child can present with erythroderma, and you can see this kind of different advancing edges of scales. Okay, this is not like usual erythroderma. There's no desquamation. There are areas which are spared of desquamation, and you can actually appreciate that one side of the plaque has scales, other side doesn't have that much scale. And if you look at a magnified picture here, let me change the color. You can see two layers of scales. Okay, so double scale or double peeling at one edge. You can easily see two layers here. Okay. And this picture is from Bologna. In fact, here also you can see the polycyclic margin at one edge. You can see it is more erythematous to one end, more scaly at one end. That's what we mean by Ichthyosis linearis circumflexa. Now this is Trichorexis invaginata, and you can easily see that here the hair shaft has gone inside the other hair shaft. Okay, so that is Trichorexis invaginata, and here you can appreciate that the hair shaft is twisted on itself, like somebody has rotated it. Like if this is the hair and you apply rotationally pressure like this, that is what is known as pillae torsi. Let's move forward. DDs include erythrodermic forms of ARCI, which is autosomal recessive congenital ichthyosis, Omenn syndrome, inflammatory peeling skin disease. Just remember them for theoretical reasons. Complications are important. Complications of Netherton syndrome are hypernatremic dehydration, severe infections, malnutrition, enteropathy, dermopathic enteropathy, recurrent infections including HPV. They may develop squamous cell carcinomas, giant condyloma of Buschke-Lowenstein, arterial hypertension, pulmonary artery stenosis. These are all complications listed in the book. Okay, let's move forward. Now, how to investigate a case of Netherton syndrome? In 90% of the cases, you can get SPINK5 sequence analysis. That means you look at the gene, you see if it is mutated or not. If it is mutated, you have a diagnosis of Netherton syndrome. So that is the investigation of choice. You can also look at the levels of LAKTI antigen in the epidermis, and this antigen is responsible for kallikrein processing. Remember, the problem lies in kallikrein 5 and 7. So if there's decrease in LACT, it will it's a surrogate marker for dysfunctional kallikrein. Okay. If you do a biopsy, you will see psoriasiform dermatitis with parakeratosis because there is scaling, acanthosis because thickening of skin, atopic dermatitis, and peculiar eosinophilic material. Remember, there is increased IgE in Nethertons. So you will see a peculiar eosinophilic material in biopsy. This altered lamellar body secretion, loss of corneocyte adhesion. Remember, the problem lies in the corneodesmosin gene. So corneocyte adhesion is defective. We can do a trichogram, which will show Trichorexis invaginata. I've already told you what it is. It may not be seen in less than 1 year of age. And eyebrow hair is very important. If you want to look at the hair, Trichorexis invaginata, you pluck some eyebrow hair and you look at it there. The earliest changes of Netherton syndrome is seen in eyebrow hair. Okay, so in fact, sparsening of eyebrow hair is one of the signs. Right. Uh, mhm. Yeah. So sparsening of eyebrow hair is one of the features in an infant of Netherton syndrome. Okay, so let's move forward. Management includes intensive medical care immediately after birth, amnion membrane allografts to take care of anywhere where the skin has shed, or are there any eye issues. Recurrent infections require antibiotic treatments. Regular bathing, emollients, and ointments which are paraffin based, that are very important. Topical steroids are not that good. So we may look at erythema and think that we should start topical steroids. They are not they are not helpful. Topical calcipotriol, UVA radiation, 0.33% brimonidine, they have worked in facial erythema in some papers. In other papers, they are not found to be that useful. So the use of these agents is doubtful. If there is nut or fish allergy, then dietary restriction would help. Screening for recurrent infections, including HPV infection, should be done. So after Netherton syndrome, we go with peeling skin syndrome, the second disorder in disorders of cornification. So peeling skin syndrome type B, the second type. So peeling skin syndromes are heterogeneous group of generalized and or palmoplantar disorders. What do we mean by that? It means that it's a group together. It's a group formed uh, including all the disorders in which there is peeling of skin. Clear? The older name is peeling skin syndrome type 1. So type B was initially called type 1. Remember, not to confuse between B and 2. Type B was type 1. It was also known as inflammatory peeling skin disease, and by inflammatory we mean to say that there is background erythema. Okay, so there's lifelong skin peeling and itching, pruritus. It is caused by autosomal recessive loss of function mutation in corneodesmosin gene. Remember corneodesmosin problem leading to ichthyosis. Now, corneodesmosin have glycine-rich domains, which undergo sequential proteolysis leading to peeling. So, what do we mean by that? We mean that corneodesmosin gene is attaching itself via glycine-rich domains. And slowly, glycine undergoes proteolysis, and because of that, the glycine residues are removed from corneodesmosin. And when these glycine residues are removed, the attachment becomes looser and they shed off. So that is how normally the skin is shed. But if corneodesmosin is mutated, it is not able to shed it properly and you have thicker scales coming out lifelong. So that is the pathomechanism or pathology underlying peeling skin syndrome type B. So at birth, there is ichthyosiform erythroderma and spontaneous patchy peeling. There are recurrent episodes of peeling with severe pruritus. Itching is there. Remember, it's an inflammatory peeling skin disease, so itching is there. It persists throughout life along with severe atopic manifestations. But hypotrichosis, that means loss of hair, and failure to thrive are less than what we see in Netherton syndrome. So it is slightly better in that aspect as compared to Netherton syndrome. The management in management, if we biopsy the skin, we'll have subcorneal splitting with and without enhanced detachment of corneocytes. In fact, corneocytes cannot be seen properly on H&E staining, so we have to immunostain them. So on immunostaining, we can see the corneocytes, corneodesmosin, which is decreased. There is no effective treatment as per se, but the calcitol cream and emollients with dexpanthenol and antiseptics. So these are the agents which Rooks mentioned. But what you can use is good amount of emollient, paraffin-based emollients, antihistamines, or sedative agents for itching. And antiseptics because skin barrier is not working properly, so recurrent infections can happen. Protein replacement therapy is in future. That means you replace the defective protein and then everything should be all right. Okay, let's move forward. The third disorder of cornification is acral peeling skin syndrome. It has been recently reclassified as an epidermolysis bullosa subtype. So if you go back and see our videos on epidermolysis bullosa, you will see that we have discussed acral peeling skin syndrome there. So it was initially described as peeling skin syndrome type 2 and type 4. Remember, type 1 is now type B. It is caused by autosomal recessive missense mutation in transglutaminase 5. Rarely the mutation can be there in cystatin A, but majorly the mutation is in transglutaminase 5. So I would request you to go back and see the video on basics of keratinization to understand the function of transglutaminase 5. It leads to superficial painless peeling. Remember, painless peeling of the skin, especially at the dorsal aspects of hand and feet, and that is why it is known as acral on the acral sites. Mechanical factors, that means trauma, mechanical trauma, and humid warm environments can aggravate the peeling. So coming to the fourth disorder, the peeling skin syndrome type A. So it is generalized, okay, generalized, non-inflammatory. Remember, peeling skin syndrome type B was inflammatory. Non-inflammatory, asymptomatic skin shedding with areas of hyperpigmentation. Remember, type B was itchy. Okay, type B was itchy, but type A is asymptomatic. It was also known previously as keratolysis exfoliativa congenita, that means congenital keratolysis exfoliativa, or familial continual skin shedding. These were the older names. It was initially classified as peeling skin syndrome type 3 and 6. It is because of recessive missense mutation in CHST8, and this is a gene which encodes for a sulfur transferring enzyme. Remember, if you remember about our discussion or our video on basics of keratinization, we know that we require sulfur residues between the proteins for adhesion and proper attachment. So that is required. Okay. If a sulfur transferring enzyme is mutated, the sulfur is not there to make sulfide bonds. If the bonds are not there, then the adhesion is not going to work properly. Additional mutations have been found in filaggrin 2, and this leads to decreased corneodesmosin. Okay, normally filaggrin 2 is found throughout the stratum corneum. Okay, but if it is mutated, you will not find it there, and the corneodesmosin protein or corneodesmosomes are not properly formed. This usually presents in 3 to 6 years of age. There's no skin blistering, redness, or acidic disorder. So major points to remember is, if I change the color, major points to remember is that it is generalized, it is non-inflammatory, and it is asymptomatic. It also occurs at later age, and the mutation is not in corneodesmosin, but in sulfur transferring enzymes. Okay, let's move forward. So we'll see this table again. We have already, in the previous video, we have discussed the first group. The second group, which are the disorders of cornification, includes Comel-Netherton Syndrome, peeling skin syndrome type B, acral peeling skin syndrome, and peeling skin syndrome type A. These are because Netherton is because of SPINK5 mutation, which encodes for serine protease inhibitor Carl type 5. Peeling skin syndrome type B is because of corneodesmosin mutation, which encodes for corneodesmosin. Acral peeling skin syndrome is because of transglutaminase 5 mutation, more than cystatin A, which encodes for transglutaminase 5. Peeling skin syndrome type A is because of CHST8 mutation, which is a sulfur transferring enzyme. Clear? Let's move forward. So I've made this video using Rooks, Bolognia, Fitzpatrick's latest editions, and you can go through that. But if you have gone through this video quickly, you don't require. Just understand the concept, what is happening in this kind of syndromic ichthyosis. With that, I would again request you to become a member of the channel. It's at a discounted rate this year till 31st of December at about 59 a month, and a lot of good things are going to be there for members only. And I've already have a separate video for announcing the membership. You can go through that. It's there on the channel. I'll put the link in the description for the membership and for the membership video both. So with that, thank you for watching this short video on cornification disorders leading to syndromic ichthyosis. We'll meet you again in the third part of the series and the final part of the series, in which we will discuss about neuroichthyosis syndrome or ichthyosis syndromes in which there are the brain issues, brain involvement, neural features. So with that, I will say goodbye, adios, bye-bye, and in few minutes, we'll discuss the third part, neuroichthyosis.